তুষার ভাই জাস্ট 10 সেকেন্ড পরে কথা বলা শুরু করলে হবে। Sir, you can start. Yes, sir. You can start now.
Okay. Assalamu alaikum and good evening, everyone. Today we have our ECG Basic and Beyond session. Today's session is case-based studies on ECG. We have among us our international advisor, Professor Rafique Ahmed sir, Chowdhury Hafiz Hassan sir, Professor Atahar Ali sir, Abdul Wadud Chowdhury sir, and all other dignitary teachers. Before starting the program, I request Professor Atahar Ali sir to say a few words about Kaiser Nasrullah sir and Mohammad Firoze sir, our presenters of today's session. Atahar Ali sir.
Actually, today we have started a new dimension of our sessions. At the beginning of the session, actually, we want to express our deep sorrow and condolence for our Professor Abdul Chowdhury's mother. She has expired few days back. But with all this problem, Professor Abdul Chowdhury is still with us. I like to request Professor Abdul Chowdhury to say something about today's program. Professor Abdul Chowdhury.
Assalamu alaikum, everyone. I'm very much grateful to everyone. So many people has shown their sympathy, paid their homage and condolence to me. My mother died 3 days ago. She was 90 years old. My father died in 1976. I was then 11 years old. We are 6 brothers and 1 sister. And my mother, she was a lady of sheer iron will and determination. She made sure that all of us have proper education. All of us grow up as a good human being. We have 2 engineers, 2 doctors, a pharmacist, a banker, a businessman, and a doctor, 2 teachers amongst us. And among doctors, that means I am PhD holders. And all this has been possible because of her determination. I'm really grateful that so many people have shown their respect to her. And she belongs to an era where the family values, the importance of education, the importance of being a good human being are given much more importance than only acquiring money or wealth or fame or name. And that's the teaching that she has instilled in us. Pray for her so that God Almighty give her Jannatul Firdaus. And pray also for all of us, 6 brothers and 1 sister, so that our progeny can make ourselves proud. They can also become good human being, not only successful, but good human being, as my mother has been able to do with us. Thank you, sir.
Thank you, Professor Chowdhury. And so again, Professor Abdul Wadud Chowdhury, can we start the session today right now?
Yes, please, please.
Acha, do you want to introduce? I request you to introduce Dr. Kaiser Nasrullah Khan and Mohammad Firoze, today's two faculties.
It's my pleasure. Kaiser and Firoze, both of whom we have been together since our student days. I was just a teacher. They were just a student at that time in NICVD. But Firoze has been my student since MBBS, third year, and Kaiser in post-graduation. And both of them are very good student, very good physician, very inquisitive, very much eager to challenge and to learn, to think otherwise, to dare to ask questions. These are the hallmarks that has made them quite different from others. Kaiser Nasrullah Khan, a very good interventionist, very fearless interventionist, I would say, who has done the first retrograde intervention, coronary intervention in this country. And Firoze, he is a born teacher, and he likes to teach. And in that regard, he's very successful. Today, we are going to enjoy their presentation. I hope I am, like each and everybody, are very much waiting what surprises they will pull to us. Thank you.
Dr. Firoze. Hello, Firoze. Hello. Sir, let us make a plan as because Dr. Hafiz Bhai is busy. So let us start with Dr. Kaiser Nasrullah. Then we'll invite Dr. Hafiz. Then you.
Okay, sir.
The sequence will be Kaiser Nasrullah, then Hafiz Bhai, then Mohammad Firoze, and finally the Rafique sir. So you can plan like this. So you can invite Dr. Kaiser Nasrullah Khan as a first speaker.
I request Kaiser Nasrullah Khan for his speaking. We can see your screen. Can you make it louder, please? A bit louder, your voice.
My voice.
Yes.
Okay. Now can you hear me?
Not
low, sir.
Not very distinct.
Then internet problem. Okay, let's see. Am I audible now?
Not that much. Can you use any headphone or like this?
Headphone I don't have. Anyway, I will speak loud. I'm very sorry that I don't have headphone today.
স্যার কিছু শোনা যাচ্ছে না।
কিছু শোনা যাচ্ছে না? আচ্ছা, প্রবলেম এটা। দেখি মিউট নাকি এটা?
না না, আপনার ভয়েসটা আসছে কিন্তু খুব মানে একটু জোরে বলতে পারলে হয়, কোনো কারণে খুব আস্তে আসতেছে।
হ্যাঁ, কাইসার ভাই আপনি কি ম্যাকবুক ইউজ করতেছেন?
না ম্যাকবুক না, ম্যাকবুক হলে তো ক্লিয়ারলি শোনা যেত। এটা এইচপি।
নাও বেটার। ওখানকার সাউন্ডটা দেখেন, সাউন্ড ইস ভলিউমটা বাড়াই দেন।
না
সাউন্ড আউটপুটটা একটু বাড়ান।
আমি হাইয়েস্ট দিয়েছি। এখন শোনা যাচ্ছে?
এখন বেটার।
জি স্যার, ইটস মাচ বেটার।
কিছুটা শোনা যায় আর কি। হ্যাঁ,
আচ্ছা, আমি কাছে এসে বলি। আচ্ছা, আসসালামু আলাইকুম and good evening to all. My deepest condolence and regards to the mother of Professor Wadud Ahmed Chowdhury. I would say she's a wonderful woman because she's known by her sons and daughter, and we are privileged to know one of his son, Professor Wadud Chowdhury, who is a versatile cardiologist, doctor, good human being, and a tremendous teacher who taught me, who taught us all, and who shared his who has a passion for teaching for juniors. So, Inna Lillahi wa Inna Ilaihi Rajiun, may Allah bless her Jannah. And thanks to ECG group for inviting me. Though I am not an ECG guy, but as Atahar bhai told me a few days back, I said he said me to show 2 ECG, and I have just collected 2 ECG, a very simple one. But let's start. So I've been asked to show 2 ECG. I picked up 1 ECG, which is a very simple one. You can all see this is 12-lead EKG, and so any comments on this? This patient presented to me with chest pain and hypotension, and also he was in cardiogenic shock.
Sir, you can go for slideshow mode.
Unmute kore dao.
Slideshow mode.
Yes.
এটা আমাকে দিয়ে দাও তাহলে।
So, okay. I thought it would be discussion. Anyway, then when we find an ECG, you can see it's a clear-cut case of inferior MI, ST up in 2-3 AVF, and when you find this type of EKG and there is a hypotension, usually if the lung bases are clear, we think of another diagnosis, and we all know that thing that we have to take in a right-sided lead. And when we took a right-sided lead, we especially focus on V3, V4, where if we found that 1 millimeter ECG ST elevation, we diagnose it as an RV infarction. And for RV infarction with inferior MI, we should look for this EKG. Especially we don't look for it, we might miss it, because if in inferior MI, 25-30% cases are associated with RV infarction. So this is a 12-lead ECG showing acute MI inferior with right ventricular infarction. And we know there is some exception of QF in lead 3s. And it is rarely an isolated phenomenon. It is usually associated with inferior MI. And the incidence of right ventricular infarction is lower due to smaller mass of right ventricle, lower tension within the right ventricle wall, richer collateral circulation of right ventricle. And for EKG diagnosis in the setting of AMI inferior, we should take a V3, V4R ECG isolated lead, where if you found ST elevation more than 1 millimeter, we can make this diagnosis. And even after, without that, to see in the setting of AMI inferior that ST elevation anterior leads mimicking anterior MI, but here there is gradual decrease of from right to left, and we suspect RV infarction. And ST elevation in V1 and with ST depletion in V2, discordant relationship to think of RV infarction. And some points to ponder that if we found it is usually associated with hypertension, increased JVP, and again with clear lung base. And to diagnose this, we should be careful, because we need to raise the JVP and right ventricular load to maintain the cardiac output. And at that time, we gave a very fast normal saline, 2 to 3 liter, to maintain the pulmonary JVP 18 to 20 millimeter mercury. We use inotrope like dopamine, and we should do reperfusion or primary PCI. We should be cautious to use dopamine and morphine, morphine and nitrates, because they take the hypertension more. But most of them spontaneously improve within 40 to 70 hours after acute event. So this is one ECG I've shown now, and now I will show you a case 2.
Kaiser, I think we should discuss this ECG first. The
Okay.
number 1 ECG first, and I think we should discuss the ECG diagnosis, then the management part.
Okay.
So, Kaiser, can you go to the ECG?
Yeah, can you show the ECG?
Kaiser, can you predict from this ECG what coronary, that is either which was the culprit vessel from this ECG? Can you predict?
Yeah. Mani,
Culprit artery.
I think it's RCA.
So any comments, Firoze?
Sir,
You can
in
invite
fact,
the panelists.
I'm going to show some ECG for localization of the culprit artery. In fact, in this ECG of Kaiser Bhai, it is definitely inferior MI, and with RV infarct, most likely the patient has got a proximal RCA lesion. That is the artery localization of this patient. This patient has got inferior MI, first degree heart block with RV infarct. So when inferior MI with RV infarct, we think that it is a proximal RCA lesion.
Firoze, Rafique sir. Hello sir. Whether Rafique sir is here or not?
Sir, let me see. Yes.
I'll leave this discussion, but definitely right coronary. But the question is, there is ST elevation in V1 and V2. So my question is there a possibility of involvement of the LAD or not?
Sir, I have got another question to you, sir. Sir, it is the RCA proximal lesion, but there is no conduction defects. Is there any explanation, sir?
Oh, so the question is right coronary artery, but we see a lot of patients with inferior MI, they don't develop heart block. It is possible that the AV nodes, some of them are supplied by the right coronary artery, some of them have dual supply, some by the circumflex. So that is the reason that not all inferior microinfarction patient develops heart block.
Chowdhury Hafiz bhai. Ji.
So let's look at the overall presentation of acute inferior ST elevation MI that we are talking here. So Marriott describes that if the 2-3 more than the AVF, there's maybe chances of left circumflex dominance is there. But I don't go too much into that. And then whether there is any reciprocal changes in the precordial leads. And if the reciprocal change is proportionate, meaning 2-3 AVF, if the ST elevation 2 millimeter, and then same, then this is reciprocal. But if it is more than that, and you have dominant R wave, and then upright T, then is a posterior. And with inferior posterior extension, it is reasonable to believe that the infarct size is big. And then you take the picture whether the patient is hypotensive or not. If the patient is hypotensive, there is involvement of RV infarct, and we can verify that before. I tell the emergency room, don't waste your time by doing the right-sided lead and then call us. You can call us first because we have this issue with the door to balloon time. But when the patient is hypotensive in the absence of nitro, which should be avoided anyway, we are in a bad situation. So inferior MI, few things to look at. One, that whether associated cardiogenic shock or not, what is the rhythm? Now it all depends on RV infarct, but the RV branch coming from where, which part? So that will determine, and Kaiser can tell us what he found in this case. And then the rhythm, I get worried if there is a tachycardia with RV infarct, with the inferior infarct, because it may affect, particularly if the patient is in cardiogenic shock, there may be pap muscle dysfunction or rupture, and there may be a mechanical complication with the inferior MI. So these are the global perspectives when we look at an EKG and then immediately think about the patient and correlate. Another important thing with the inferior MI, that is it all we have, as Rafique bhai mentioned, that there is in this case, there is lead 1 and AVL has ST depression. Is there something disease going on in the other side? That is also important. And by rule, any inferior infarct presenting as ST elevation, we always think about the differential, that this is not nasty thing like ascending dissection going into RCA. And therefore, a cardiac auscultation, AI, and particularly if the patient is in hypotension and shock, we immediately do a bedside echo, make sure that the root is good and there is no pericardial effusion. These are the things to always remember when we deal with this ST elevation in the inferior leads. These are like very basics, and I think it should be in the brainstem, not in the cerebral cortex.
Hafiz bhai, the ST depression in lead 1 and AVL, whether these are reciprocal change or due to the ischemia on the other side?
It is difficult to say because reciprocal is normally we reserve for the precordial leads. And usually reciprocals are like horizontal ST depression type. Here you can see that it is a downsloping ST depressions in lead 1 and AVL. I don't want to read too much in the EKG, there is a suspicion that either this is a big RCA and giving PL branches, or there is a separate lesion in the circumflex OM. The another important thing, why we do about this EKG, because dot to balloon time sometimes can be T20 cricket, because we have like in the lab, by the time we reach, it is 80 minutes and we have 10 minutes. So should we go with the diagnostic catheter on the other side? And Kaiser will appreciate that what I'm saying, or that we do diagnostic first, or we go up with the guide, because that's a couple of minutes can make a difference, you know, because I call it T20 cricket, because after 90 minutes, we miss it and we'll be labeled as, you know, in a binary way that dot to balloon time not achieved. So that becomes a problem. Then, so when I start in the lab, I check what is the time and what should we do, look at the EKG, and then go from there.
I think Wadud bhai can make a comment. ST depression in lead 1 and AVL, reciprocal or ischemia? Professor Wadud?
There is ST lesion in inferior leads. If you got a depression in particularly in AVL, look at the inferior wall, look at lead 3, where the ST lesion is highest, and opposite to that is the AVL. And if it has that classical ST depression, it really supports your diagnosis of acute ST elevated MI. And you can rest assured that if you do the intervention or if you do the thrombolysis, whichever you prefer or is able to do, you will do much good to the patient. The problem here is the ST elevation in V1, V2. What does that suggest? One thing is that ST elevation in V1 as a whole is suggestive of, in the setting of acute inferior MI, is suggestive of coexistent RV infarction. If the patient has hypotension and if it is not induced by nitrate or even induced by nitrate, both of these are very supportive of their diagnosis. Again, if the patient had atrial fibrillation, that will also suppose that sinusoidal artery is affected, right atrium is infarcted, that's why the patient is having atrial fibrillation. All those are suggestive of very proximal RC involvement. The second, concomitant anterior infarction. Sometimes the RV branch, the conus branch, can be very big. It can supply the anterior wall, and thereby, even with RC involvement, we can have some ST elevation in anterior leads, V1, V2.
Atahar bhai, can I make a comment, please?
Yeah, sure, Khalid bhai, you're welcome.
Yeah, we just take notice that the precordial lead, some of the leads are recorded in half voltage. So there is the R wave in lead 1 is about 15 millimeter, and AVL is more than 11 millimeter. So the patient might have some left ventricular hypertrophy as well, and this may be the changes in the 1 and AVL may be attributable to the hypertrophy. left ventricular hypertrophy. There might be coexistent left ventricular hypertrophy as well. Because
excellent observation, Khalid bhai. Thank you very much.
Professor Atahar.
Yes, sir.
Professor Atahar.
Yes, sir.
I'd like to make a comment that here there is a key wave in 3 and also AVF, but not in lead 2. Not in lead 2. At the same time, there is only V1 Q wave, but in V2 there is no Q wave, only ST elevation, and there is a deep ST depression in 1 and AVL. And can it be this ST elevation in V1 and V2 a reciprocal of changes of lead 1 and AVL? And if the blood pressure is not very low, then we cannot say it is right ventricular infarction. Maybe a small inferior MI, but ST depression, whatever may be caused, maybe due to acute ischemia also in the 1 and AVL, which may lead to ST elevation reciprocally in V1 and V2. In V2, there is no Q wave, no definite infarction.
Sir, in general, whenever there is hypotension, we expect there should be sinus tachycardia. The only place
that's true.
there is exception is when the patient have inferior MI with RV infarction, where we do not usually get the expected sinus tachycardia. That also suggests this is the case of acute inferior MI. And the patient was in hypotension. Kaiser, what was the pressure?
It was 80/40, something like that.
40, yes.
And let me ask the panel about the precordial lead.
Another cause of hypotension. Another cause of hypertension maybe due to acute ischemic change in the lateral wall, because 1 and AVL there is deep ST depression. This may not be reciprocal from inferior MI. This may be spasm or non-ST in the lateral wall, left lateral wall.
To echo with Professor Jalaluddin's comments, let me tell you one thing though. We all know that the pure RV infarct is very rare. Most of the time when we see RV infarct, there is some involvement of the posterior wall of the LV. So, and therefore you always look at whether there is an ischemic MR or not. But let me ask you one thing, that the ST segment elevation in the precordial lead, like V1, V2, if that is the only thing this patient presented with, do you have called it ST elevation MI in the anterior?
This is the question actually.
This is question. My opinion is that because there is, in addition to the inferior MI, there is gross ST depression in V1 and lead 1 and AVL, and for that the reciprocal ST elevation may be in V1 and V2. That may be separate entity from other than the inferior MI.
Sir, actually, this is
in anterior leads. There should be reciprocal changes, ST depression in inferior leads. That is not the case.
Yeah, and the other thing is that there is a term called distant ischemia, but ischemia itself, so when we call reciprocal, from transmural injury pattern in one area, the reflection of ST changes in the opposite area is defined as the reciprocal change, if it is proportionate. If there is more than proportionate, then it is additional ischemia. But ischemia in one area does not give reciprocal ST elevation in the other area. That is not the case. So we'll have to take this ST elevation independently, whether this is a true reflection of something going in that territory or not. And my vote is that that alone in this case does not fulfill the criteria of the ST elevation to call for anterior wall MI if this patient comes in. However, the clinical story is more important because we call a STEMI on the basis of interpretation of the EKG and the patient. So we'll have to take this together.
I think.
Sir, may I recommend, sir?
Yeah, Asad Zaman. Yes, welcome, Asad Zaman.
Sir, I have seen that there is a one important term is in case of RV infection is the disproportionate elevation of ST segment in V1. If we consider the ST segment in V1 and V2, we can see here that the ST elevation more in V1 than that of the V2. It indicates there is a RV infection, no doubt. Number one issue, sir. Second issue is if there is a type 4 LED. In that cases, there may be ST elevation in V1 and V2. At the same time, there may be the ST elevation in the inferior lead as well. I have two comments are here.
So I think excellent discussion.
May
Jamil,
I add a little thing?
Acha, you are the last man to comment. Yes, welcome, okay. Jamil.
I have seen a case, I did angiogram in that case with this type of ECG, who had PDA cam was continued, the LED hooked around the apex and went up to the crux. So it's a long LED that covers up to the crux in the inferior surface of the heart, and there was no PDA from the right side. It was from the LED, not from LCX also. So in that case, this scenario might come, and it's a very rare occasion. Thank you.
Can I add something? Hello?
Yeah, Wadud bhai, welcome.
The point is, if it goes the wraparound LED, you'd expect to have ST elevation more in lead 2. Here, lead 2 is almost non-involved.
Right. So, excellent discussion, and Kaiser, Nasrullah, thank you very much for your beautiful ECG. But we want to give a message to our participants that there are some excellent discussion. We have to carefully notice all the things, as because there is ST elevation in V1 and V2, ST depression in lead 1 and lead 2, and also Khaled Mohsen has also noticed there is standardization, that is the half standardization in the precordial leads. So all the points we have to notice, but finally we have to give, these are all the points we have to discuss. But we have to finally come to a conclusion for the management of the purpose. An excellent discussion. We have to, this is the beauty of the discussion, that we have to see all the things. And for our participants, that is, we have to make a final clinical diagnosis for the management of the patient. That was the inferior infarction with RV involvement with the, that is the cardiogenic shock. This is the diagnosis, Kaiser Nasrullah.
Yes, yes.
So let us come.
See proximal lesion.
So come to the management expert. How did you manage this patient? Did you put the patient in the cath lab or is the conservatively managed?
I definitely took him to cath lab, but I put him lots of normal saline like 2 liter very running, and took him to with dormant support. I took him to cath lab, and there is a RCA proximal lesion with lots of thrombus. I need to suck it out, and then after a while I put a stent. And LED and SARC has got non-significant lesion. It was not free of disease, and what I've emphasized that we have to give a normal saline running 2 to 3 liter to keep the JVP 15 to 18 mm, and also dormant support to combat to make the RV output more, keep the LV output. So that's my key message to the juniors, that seek for RV infection when you're dealing with the inferior MI ECG, and if you find any, then give normal saline running, give dopamine, keep the RV output higher by stretching the RV wall, and then if whatever you do, if possible, to take for primary PCI, if not possible, thrombolyze the patient. That's my message. And try to avoid nitrous and morphine in this case.
Second ECG, Kaiser.
Echo was good, right, Kaiser? Echocardiogram.
Yeah.
LV function normal, no mitral regurg.
No regurg. LV, I think, I don't remember exactly, but I think it was near normal, 40 to 50% maybe.
Yeah.
but no MR, no regard.
Second ECG, Kaiser.
So I just want to add one thing to Kaiser's comment about the management. The RV with all these, what Kaiser said, you give fluid and all that, but then it does not get better. And if it is a delayed presentation, the RV does not get better. So what do you do then? It becomes a very challenging. One thing we all cardiologists should appreciate, that RV is kind of a neglected chamber. If RV goes down, the whole cardiology goes down. It's very difficult. It is in good news that RV is resilient. It comes back if you can give the support. But during the supportive phase, if the RV does not get better, then RV failure is a big problem. So you can then, what do you do then? What do you do then? So some has tried inotrope, digoxin, but if that doesn't work, then you need to think about reassessing, make sure there is no mechanical complications, do a right heart, look at the PAPI, pulmonary pulsatility index. If the PAPI is low, you need to give RV support.
Is there any choice?
How do you do that? How do you do the RV support, Hafiz Bhai? Can you please clear this point?
So one is the dire situation is you go to give RV impeller, right? And the other one is that you up titrate with your pressors, because you need, because if the volume becomes a problem, volume helps you in the beginning, but now the RV is dilated and failing, then if you give volume, it's not going to work, because the RV cannot take this high preload anymore. So if you're giving fluid and the RA pressure or the CVP is going high, now 2024, and RV is not working, then it becomes a problem. So you need to back off, give and leave with the lower cardiac output as you can. And that becomes a problem. And that is where Professor Jalaluddin's comment is very important, that is the ILV involved as well? Because if the right heart will tell you, if the wedge is normal, then you have more room to give fluid. But if the wedge is also high and the RA pressure is also high, then you know that you are in a bad situation. You are dealing with both left-sided and right-sided failure. If that is the case, then it becomes a little bit easier. You can try LV support and then see. But you need to calculate the cardiac power output and the PAPI and see only LV support will work, or you need both LV and RV impeller. That becomes complicated. I usually do in this situation, I start doing hemodynamics, and I keep in touch with Eric from Heart Failure Transplant Center, and then communicate with them how to do.
Hafiz Bhai, what is your usual practice in your center? That is, do you do the invasive monitoring in all the cases of the RV infarction?
Invasive monitoring is two ways, right? If the patient is not cardiogenic shock, then I don't do the right heart as a routine. But if the patient is cardiogenic shock, we do invasive. Yes. Right.
Firoze. Second ECG, Rafique sir. It is 9:50.
Can you show the second ECG? But before.
No. Yeah, Firoze, I am done. You start with your slide.
No problem. Then you can invite Hafiz Bhai, Firoze.
Thank you. Thank you. May I request Professor Hafiz sir to show his ECGs? Hafiz sir. Before Hafiz sir starts his presentation, this is one important thing what Hafiz sir said, that giving fluid, you cannot give fluid without any limitation, because this fluid in the RV works by Frank-Starling law, and that works within a certain limit of volume. If you crosses that volume, then this extra amount of fluid will lead to extra burden on the RV, and it will increase the RV failure. So giving fluid without any limit is not a good idea for RV infarction.
We can see Hafiz by screen.
Hafiz sir, please.
Slide share mode.
Hafiz sir, we can hear you.
Slide share.
Can you see my slide? No?
Yes,
All
we
the
can
slides,
see you.
all the slides.
But
Okay.
in a slide sorter mode, you can go for slideshow mode.
Yeah. As long as, okay, good. 60-year-old male post-resuscitation found unconscious, and we always ask, what is the first rhythm observed? First rhythm observed is the PEA, CPR, ACLS protocol, ROSC, field intubation, no name. And this is the vitals when the patient arrived in the hospital. And this is the EKG. I would request you to look at the EKG first, and then I will request you to look at the strategies that you would follow. So look at the EKG first. This is a little noisy EKG. Sorry for that.
We can see your ECG.
Cannot, yes.
We are still seeing your first slide.
You can't see my EKG?
Yes, you can.
I can see.
Okay.
Okay. And do you see the suggestions, the answers, like the following Rafique Bhai's sort of presentation? Suggestions: A, therapeutic hypothermia protocol, supportive care, correct metabolic derangements. B, immediate angiography, revascularization, hemodynamic support. C, rewarming and supportive care and correct metabolic derangements. And D, temporary pacing, supportive care and correct metabolic derangements.
Review, you can arrange poll, just few minutes, a few seconds, and then poll.
I think they will not be able to arrange poll at this very moment. They are not ready.
Sir,
Okay.
we can start. Will we start?
Yes, you can go for poll.
Okay, starting, sir.
I'm starting the controversy, so I'm very curious to see. We have about 100 participants, I see.
What is the temperature of that patient?
That is also part of the ECG interpretation.
Sir, should we go for 20 seconds or 30 seconds?
30 seconds.
30 seconds, okay.
Okay, we can stop it now. So 17 out of 76 voted for it. 41% says it's C, rewarming and supportive care and correct metabolic development.
B and C.
Otherwise, last comment, increase the poll to the Democratic Party. So any comment by anyone?
Looks like a Wasborn wave.
Final comment from Rafique sir, but before that, from panelist.
Yes, otherwise probably this patient had received therapeutic hypothermia as a management protocol of cardiac arrest, and the effect of hypothermia is visible on the ECG.
Just telling Khalid Mohsin, this is immediately after arriving in the hospital, this EKG.
Oh, okay. And I thought it's
after resuscitation, immediately.
Yeah, and then and as you know that we don't do the therapeutic hypothermia. We follow the mild protocol now. We don't do the aggressive hypothermia protocol. And Osborne Webb following therapeutic hypothermia, then we are in deep trouble.
Hafiz bhai.
Yeah.
First of all, let us make the ECG diagnosis first. What is the ECG
Yes.
diagnosis?
Yes.
Wadud
Any
bhai.
comment? Any
Wadud
comment?
Wadud bhai, what is the ECG diagnosis? Or Jamil, what is the ECG?
We got involved, cardiology got involved because the emergency room physician called it STEMI. So that's why I was involved.
This ECG actually shows there is bradycardia, profound bradycardia, and it is sinus rhythm, as most of the complexes are preceded by P waves. There is ST elevation in the inferior leads, these 2, 3, and IVF with concavity upwards, and as well as in the lateral leads in lead V6, V5, V6. So, and in AVR, there is ST depression, convexity upward. This one feature, this may be pericarditis, maybe due to prolonged resuscitation, and STEMI should be ruled out.
But this is the ECG of a patient that is a cardiac arrest survivor. True,
Yes,
Hafiz bhai?
Yes.
Cardiac. This is the ECG of a patient who has just survived from the cardiac arrest. So
STEMI is a very probable diagnosis.
So that is the dilemma, right? If it is a STEMI and you are buying that, then you need to go to the cath lab.
Right.
Yeah.
Or do something.
Sir, may I add one point, sir?
Yes, sir.
Sir, may I add, sir?
Yes.
Yeah.
Zaman.
Sir, actually, there is a on the background of sinus bradycardia, there is a RBB morphology, and this RBB morphology is an important issue here due to it may be whether there is a Brugada or not is it's not clear to me yet, but there's another important finding is there is a RBB here.
Rafique bhai, on this comment, I would not entertain Brugada here.
And
Well, I mean,
RBB is not here.
Yeah.
The RSR pattern is not there in V1, and R wave is small in F1.
Rafique sir.
So I tell you what happened here, because for the sake of time, Atahar bhai.
No, Hafiz bhai, actually, we will just hear this final comment from the Rafique sir. But before doing that, is the STM is the first diagnosis, but early
No. This is the reason I'm showing this. We need to take this STEMI, ST elevation MI. There is ST elevation, but there is no MI here. We need to understand that. And I right away deactivated the STEM MI part. Couple of things to follow. The patient was resuscitated from the field. Patient was hypothermic. Atahar bhai, to answer your first question,
right.
I deliberately did not give you the temperature in the vitals. And I think your comment increased the number of correct answers.
Right.
and then if you are in doubt, this is a transmural MI if you want to explain this because of the cardiac arrest. But the first rhythm was PEA. Usually with the MI, the ACLS protocol, first rhythm is VFib arrest. So there's a few things. And then two things you can do before you take to the cath lab. You can do a bedside echo and see what is the LV function and whether there is any regional wall motion. And then even after that, if you cannot decide, I would request that I buy time. I tell the ER physicians that it doesn't look like MI to me, but this patient is resuscitated. Before you take to the cath lab, another important thing we learned, because if we are in doubt, even Brugada I have taken to the cath lab and then found nothing. Sometimes we get burned, but you buy time and see. One principle we follow, Nasrullah is here, we take to the cath lab and Khalid Mohsin is here, Nowadays, diagnostic cath is very safe. So some will say, what is the harm in taking to the cath lab and find out? There is harm. There is harm because this patient is shocked. The pH was actually 6.9. The potassium was high. Calcium was low, totally metabolically deranged. And the creatinine, importantly, was high, and patient also had rhabdo. We found out later. So if you give contrast,
can I make a comment?
Yeah.
So this is a patient from Las Vegas, right?
Yeah.
And who had no names.
Yeah.
So this is a homeless person lying on the street side.
Yeah.
No question about it, because in America, either you are home, people will know who you are, or if they find me on the street, they will find my wallet. I should have a name. So this patient was lying on probably on the street side for several hours before they found him. Is that true?
We don't know, but we are guessing the same way you are thinking.
Okay. All right.
So we did not do any intervention or any angiogram. Patient was intubated, did poorly, and ultimately we could not save him. He passed away a couple of days later. But LV function was normal. And the troponin was actually low. The CPK was high. It's like 30,000 plus. And it is very well known that you can have these ST changes with the hypothermia. So I'm just trying to get this in the mind of our juniors that there are several differential of ST elevation, but for calling it a STEMI, you will have to have two parts, ST elevation and MI part. So this is a good one, and I'll finish soon. 69-year-old, this is a debate. I'm admitting that it's still controversy going on with this patient, so don't kill me. So 69-year-old, diabetes, hypertension, hyperlipidemia, renal failure, cellulitis, peripheral vascular disease, presented to us with tachycardia, blood pressure was 70. So when there is a white complex tachycardia and hypotension, I pray to God that this is hypotension so we can shock. We don't need to think twice. But that's not the right way to think. And that's why Rafique bhai is here to sort it out. Question is, what is the diagnosis of this white complex tachycardia? I gave you all the risk factors. And this is subsequent EKG.
You should not have shown this one.
No, Rafique bhai. I'm showing you deliberately. And then I'm showing you even more. And I'm showing you even more. Okay. Now, my question to you is this. Your diagnosis of the initial rhythm, A, VT, I forgot to put A, B, C, D. Is it VT, left bundle branch block and sinus tachy, left bundle branch atrial flutter, left bundle branch block atrial fibrillation?
Okay. Let the audience remember this sequence and call it 1, 2, 3, 4, and let's go back to the first ECG.
Yeah, first ECG is the yes.
Can you go back, please? Okay.
So A was VT, B was left bundle branch block with sinus tach, C was left bundle branch block with A flutter, and D left bundle branch block with atrial fibrillation. Okay, so Rafique bhai, VT is 44%, and then left bundle branch sinus tach second. Let me show you further.
No. You have to go back.
Okay. I wanted to give you the floor.
No, you cannot, because you see, when I have the patient, I just have this ECG. So the patient is sitting in front of me with a systolic pressure of 70, and I have all I have is this ECG.
Yes.
And all of the audience that is listening to this lecture, they are sitting in the emergency room with a patient whose systolic pressure of 70, and this is the ECG. they don't have any more information, and they will have to make a decision based on this.
Yeah.
And our panelist needs to help the audience to tell them what is the diagnosis.
Khaled,
So any panelist, any comment on this?
Khaled Mohsin, welcome.
Lead 2, rhythm stream, 1, 2, 3, 4. The fifth beat.
Why?
The QS complex rate is around
Acha, Wadud is talking. Wadud, Wadud bhai, your just increase your volume, please.
শোনা যাচ্ছে না আপনার কথা, একটু জোরে বলেন স্যার।
আমি বলছি কিন্তু শোনা যাচ্ছে না আসলে।
No, now we can hear.
এখন শোনা যাচ্ছে।
In lead 2, 1, 2, 3, 4, the fifth beat, and then onwards, if you look at it, the rate is around 150, and if the 150 rate is there, there is a possibility that the atrial flutter could be a possibility. But if the patient has this ECG, I would always consider this as fast as VT and treat it likewise.
Okay, so let me make some comment. Okay, Khaled Mohsin.
Otherwise, I think it is a sinus tachy with LVVB.
Okay, all right. So let me.
I love it.
Okay, let me go over this ECG. The rate is 150, and it's quickly clear 150. So I have to consider a wide QRS tachycardia, two possibilities. One is VT versus atrial flutter or Khaled Mohsin sinus tachycardia with left bundle branch block. Now, if you look at lead 1, it looks like typical left bundle. And if you look at lead V6, it looks like typical left bundle. If you remember the algorithm of VT diagnosis, if you look at V1, V2, V3, the initial R wave is less than 40 milliseconds. Actually, less than 30 milliseconds. It's a narrow R wave in lead V1, V2, V3. That supports supraventricular tachycardia. There is no big RS pattern, so I cannot use any other growth. Based on this, it will be a left bundle. Other thing that we have to remember, that in left bundle, if the QRS duration is more than 160, it sometimes supports, but here I cannot use that. So I think this is a supraventricular edema, either atrial flutter with left bundle branch block. And the second possibility is that as Khaled Mohsin sinus tachycardia with, and of course, one picture that was pointed out by Wadud is this fifth beat. It's a little different, but if you look at it, it is not much different from the other beat. So my explanation of that is that even though we call left bundle, not all left bundles are complete. So there can be varying degree, and that's probably it is. So let's see what Hafiz says. Hafiz, what is your?
Rafique, I diagnosed this as a left bundle with atrial flutter.
Yes.
But this fifth beat was brought in by our EP fellow. I mean, third year fellow who is going to EP, and that shaken the whole discussion that why that is the narrow. Is it a fusion bit or is it a captured bit? So I do not know how to explain, but I cannot just keep on one beat and then throw the whole diagnosis. But given these circumstances, what will be the next move? Because if it is sustained VT and the LV function not normal, troponin 0.9, will you cath? I'll go quick because it is a management issue, but I think we need to discuss that. Anyone to think about cardiac catheterization and sort it out?
No, we are not in favor of the cardiac cath.
Okay, so now we were like, okay, let's see if this could be septic. And the patient needing levofed, and then dopamine, dose going high. ICU is saying patient is maybe septic or maybe cardiogenic, we are saying maybe septic, and then it becomes a problem. What do you do now? And the renal says, don't worry about the kidney. Whatever you need to do, we are okay. We'll give you the supportive care. What do you do?
What about the pH?
pH was 7.2 to start with. Now subsequently pH is okay. So we did actually cath because this issue came up, and then this, I don't think that this was VT, but because of this question mark with the VT, everybody was against VT except one in our group who said it's probably VT white complex, bad LV. What are you talking about? But I considered, I did the cath, no coronary disease, and then EF was 30%, but I also did right heart. Anyone to comment on the right heart?
Hafiz, how did the rate come down?
Rate came down MEO. After shock?
No, just
After,
1 second.
Shock. Synchronized
So
shock.
you shocked and the rate came down, right?
Yeah.
Was there any change in morphology of the KRS complex before and after the shock?
Okay, so that's why I showed you the subsequent after shock. This is the EKG.
No, yes. So the problem is this ECG and ECG during the tachycardia is not much of a difference. And I think your diagnosis is correct. It was supraventricular. It's probably atrial flutter with 2-to-1 conduction with a rate of 150.
Exactly, but everybody was on my nerves, and then patient is not doing well. So I ended up doing this cath because I don't want to be blamed that I'm not doing anything. So, and then I gave minimum dye, but I did the hemodynamics. And this is the right heart cath. Any comment? So now the ICU versus cardiology, CCU, is it your patient or my patient? Cardiogenic shock or septic shock?
What was the procalcitonin level?
Was that?
Procal?
LBDP. You are asking me hard questions. I don't know. I'll have to look up.
What was the Hafiz? What was the SVR?
Okay, so actually, I did not give SVR. I wanted to the audience to learn about how to do SVR calculation. But in any cases, if anybody has any comment.
The LBDP is high, 24.
Yes.
That was in favor of left heart failure. It's a CCA case.
Yeah.
Waist pressure is also high.
Yeah.
Yeah.
So we have to accept that this is a cardiogenic shock, right? Because the EDP is high, cardiac index is on the fence. Yeah. Wedge pressure is high. There is no mitral stenosis, and then PA pressure is moderately elevated, and therefore we'll have to accept that this is cardiogenic shock with poor stroke volume. So and the SVR calculated was also high. And I request everybody to learn this, how to do peak cardiac output and also how to calculate the SVR, because the blood pressure is equal to cardiac output times SVR. If you know the cardiac output, you should be able to get the SVR and SV. For that, you need to have the two ends of the circulation. The map is 60, RA pressure is 10, so 50.
Hafiz, can I stop you for a second? Yeah. We are assuming that everybody knows SVR. I didn't know it many years ago. Can you explain why you are using SVR? What is the term for? Systemic vascular registers, right?
Right.
Can you explain it in layman's term, please, to us?
So the systemic, we have two circulation. One is systemic circulation, one is pulmonary circulation. Systemic circulation is determined by the pressure on two ends, which is the mean arterial pressure and the right atrial pressure. And the pulmonary circulation is determined by two ends. One is the pulmonary circulation map, pulmonary mean arterial pressure, and the wedge pressure. These are the two ends. So if you look at the Ohm's law, the resistance will be by the flow and the pressure in two ends. Therefore, if the map is 60, in the systemic circulation, two ends, mean arterial pressure minus the right atrial pressure is 50. You divide that by the flow, you get the resistance. And that resistance is in Wood unit. You need to, that's the way we express. You need to multiply that by 80. Then you get the dynes.
Okay.
And
let me ask you this. So what is normal systemic vascular resistance?
So you take anywhere between 800 to 1200.
Okay, fine. So let's say there is a patient, Mr. Johnson. His systemic vascular resistance is 800. And within next 6 months, he develops severe cardiomyopathy and in heart failure. What will happen to his systemic vascular resistance?
Excellent question. The vast majority of the patients with heart failure, when they decompensate, their SVR goes high. And that becomes a problem because now the pump that is already weak is actually acting against a higher afterload. And that is undesirable.
Okay. Why does systemic vascular resistance go up in a heart failure patient?
Because body tries to maintain the BP. The blood pressure determines the organ perfusion. So if the cardiac output falls, the SVR goes up to compensate to get the blood pressure good.
Okay.
And that's the usual cycle.
Okay, so now let's make an assumption. So there is another person, Mr. Johnson, has no cardiac problem, develops severe sepsis. His systemic vascular resistance will go down, right?
Yes.
Okay. So instead of 800, he will be like 200.
Yes.
So that's how we will differentiate between cardiogenic shock and septic shock. Now let's take Mr. Johnson.
I just wanted to add one thing with your observation. One of the cheaper way to look at a patient and monitor SVR is to look at the diastolic blood pressure in the ward round every day. If somebody is febrile and drop blood pressure, if you see that the diastolic blood pressure was 70, now 40, and there is no anemia, there is no shunt, nothing, and the patient is febrile, you know that the SVR went down with the fall in the diastolic blood pressure because SVR maintains the diastolic blood pressure.
Okay, now I'm going to give you another scenario, Hafiz. You have to help me out here. So Mr. Johnson, whose ejection fraction is 15%.
Yeah.
And his normal SVR range was 800, now it's 1800.
Yes.
And he develops septic shock.
Yes.
What will happen to his systemic vascular resistance?
Yes, and that is the situation where we need to collaborate with the ICU guys, right? So I say this, that sometimes sepsis helps in the heart failure, but not for too long, because sepsis will try to reduce the SVR, and because of the reduced SVR, suddenly it will be convenient for the myocardium because the afterload has gone down. It will recruit more myocardium depending on what kind of contractile reserve you have. If you have good contractile reserve, you will be able to overcome this. But if you have bad contractile reserve, you may be able to get a little better at the beginning, but soon it will crumble. And then SVR will no longer be low. It will start going high. And another compounding factor, with the overwhelming sepsis, you have the myocardial depression factors, LV function, contractile function will go down. And as we go from the warm phase of sepsis to the cold phase, SVR is going to skyrocket and doomsday will arrive. So unless we monitor hemodynamically these patients carefully and titrate that way, we are not going to.
All right, thank you. This is good, Abid.
Can I say something? You have given levofate to the patient. What will do to the SVR in this patient?
Okay, so This is an important question. So levofed is going to give you the contractile function a little better, because remember this is beta agonist, but it is going to increase your afterload as well, because SVR is going to be a little high. So this, you use your judgment. Is this SVR 1300 acceptable to you, or it is already high? And your goal is to keep the blood pressure, right? Now, you can do a couple of things. You can give milrinone, for example, in this situation. If you think that the SVR is high and your filling pressure is also high, then milrinone is a better choice. But if you only rely on milrinone, you will also take the risk of arrhythmias, because milrinone is very bad. So you titrate with whatever way you can, give little bit of levofed, little bit of milrinone, and then keep the maintained blood pressure on organ perfusion. Particularly key thing is to keep urine output. But that's a very important question, Wadud. Now, if you giving levofed and escalating the dose of the pressors, you know that you are not going to be able to continue. In that situation, and there are now plenty of data that as you escalate your doses, the prognosis is bad. And you calculate your cardiac power output, and then you go for devices.
That means then LV unloading will be the much more helpful thing.
Absolutely. Absolutely. You're absolutely right.
ECMO will do the job much more.
Well, I honestly don't think that ECMO is a very good afterload or LV unloading, because LV unloading, ECMO is good in general, is for gas exchange. Gas exchange, ECMO. But for LV unloading, and this will be like a debate with bloodshed that why you are saying this. But I'm telling you my 2 cents, ECMO good for gas exchange, for LV unloading, Impella or equivalent.
So Firoze?
Thank you, sir. Sir, we missed Rafique ECG for last few weeks. Now we can go for Rafique sir's presentation, sir.
Sir, Rafique sir, I would suggest Rafique sir that this type of patients, we should have more discussion again and again in future, because in our country, we do not actually monitor the patient hemodynamically. We are not accustomed to it. But if you have the basic knowledge from this type of examples, our young cardiologists will be much more inclined to do that in future.
Wadud, excellent point. And now we have these 5 French Swan-Ganz catheters. I'm telling you, it is so easy actually to float a swan. But in the US, we are also a little reluctant because it does not give much money, but it helps a lot of information.
Firoze bhai, just a small question. Can we use like sometimes I use for when I do a PTC of a low EF patients, a multi-purpose or pulmonary balloon catheters, normal, not Swan-Ganz, the pulmonary balloon catheters to measure the PA pressures and give nitro to reduce the difference between the arterial blood pressure and pulmonary arterial pressure while doing the PTCA. It's sort of a poor man's Swan-Ganz, what I believe. Your comment.
So if you do that, you look at the pulmonary arterial diastolic blood pressure, because pulmonary artery diastolic blood pressure has a good correlation with wedge, and wedge is a reflection of LV EDP. When you do angioplasty, you are actually making things worse with ischemia, and when there is ischemia, the EDP is going to go high. If you want to monitor that, then that's not a bad idea to do. But if you want to do real proper, you know that these are things that will happen. But if you really need a proper monitoring, you're probably better off with a 5 French Swan to put in. I normally don't do any routine PA catheter and LV dysfunction patients. I usually go for supportive thing, because you may need a coronary perfusion with a balloon pump. I call it coronary perfusion help. But if you really need to unload the ventricle, then you need impella with a lower, like a CP or 2.5, 3.5 cardiac output. But depending on what you want to do, a coronary perfusion help or ventricular unloading, because you know that monitoring is helpful, but you know that that's going to happen.
Rafique sir, apni shuru koren, sir.
All right. So good afternoon, everybody. I think now we'll come back to simpler life. So my simplicity is my motto. So please start thinking simple. Don't think of liver fed, all those complex things. So first ECG, this one. Look at it a few seconds and then we'll give the poll and then
people don't know you. You have a benign face, but you actually challenge more.
But I'm interested in ECG, Hafiz, the one that you showed, left bundle with two different with QRS complex. So for some reason, I had a similar ECG today. We will look at it.
Should we start the poll?
Yes, please.
Okay, sir.
You can stop now. 52% says it's B, sinus rhythm.
Yeah. So I would like Wadud to comment on choice D, which is 10% said D. Wadud, can you tell us something about it?
Is that the answer speaks volume because it was saying biphasicity in lead 3. And we know that for ST segment or T wave changes in only one lead, I'm not going to pay attention to that.
So this is a very important point. Thank you, Wadud. Very important point that we saw, yes, I am describing that finding, and I did it on purpose, that there is biphasic T wave in lead 3. But if it was abnormal, it would also have shown in lead 2 and AVF, which it did not. So if we find this kind of isolated change, and that's why I have these two choices here, that number 3 and number 4. One I said normal ECG, other is abnormal ECG. So it's actually a normal ECG. I'm describing the finding. We should describe all these findings. So, but I think overall, this is excellent. I mean, if we say sinus rhythm, normal ECG, that's an acceptable choice. Sinus rhythm, whoever noticed the sinus arrhythmia actually paid attention to the beginning of the EKG. You see, beginning is a little bit faster, and towards the end, in the middle is a little slower and then faster. So it's a very subtle sinus arrhythmia, and thank you for picking it up. So thanks. So this is good. I think this is a success that 90% of our audience answered correctly that this is basically a normal ECG. So I'm going to the next one. Again, simple ECG. We're doing basic stuff. We can give the poll now. Okay, I think the poll is complete, right?
Right, sir.
Yeah. So well, good news, nobody called it left bundle branch. So that's good. So, but one person called it a normal ECG, which is fine. I mean, it looks fairly benign, but if you look at lead V1, there's an M pattern, and the QRS duration is wider. So that takes away the normal part. And why it is abnormal, and the question is it incomplete or complete right bundle branch block? And I think I'm willing to accept both answers because it's a little difficult to see the grid here. Also, the issue of left atrial enlargement I added. So let's look at the next ECG. If you look at it, I actually increased the grid size. I enlarged it. And if you look carefully here, it's about 110 milliseconds. It didn't go to 3 boxes. So that makes it incomplete. But if somebody said this is complete, I will not argue with that person also, because this is not really on the borderline, but it's incomplete by definition, incomplete.
Can you go
right
to the previous ECG?
What is it?
The initial.
Right.
This one, the initial ECG.
Yeah, this is the first one.
Sir, yeah. I want to draw attention to one thing. Sometimes patients with right bundle branch block, they seems to have a Q waves in inferior leads, but if you look at it carefully, actually it's not Q wave.
Rafique bhai, can I make a comment, please?
Yes, please do.
Actually, can it be a case of pulmonary embolism because there is a S1 QT3 and an incomplete RBBB?
Motion.
That's why I was saying that's where it needs.
Khaled, we couldn't hear your comment.
Be a case of pulmonary embolism. There is a S1 Q3T3 changes and incomplete RBBB.
But in that case, sinus tach is usual. Sinus tach.
Yeah, and no precordial changes as well. But can it be in the differentials?
Yes, definitely it should be in the differential diagnosis. But I think unlikely as because there is no sinus tach.
But that Q wave, as you were suggesting in lead 3, that's the point I'm saying. Sometimes people, sir, আপনার unmute করতে হবে.
Screen share.
Yeah, I got disconnected. Can you see my screen or no?
We cannot, sir. You have to share it.
Okay, I'm sharing it again.
ওখানে স্যার একটা প্রশ্ন আসছে ওই যে ওখানে যে আরবিবিবির জন্য অনেক সময় ইনফিরিয়র লিডে মনে হয় যেন একটা কিউএব এর মতো আছে। আমি সেটা কনফিউজ করে দেই এটা কি একটা এমআই আছে কিনা। যদি তাই থাকে তাহলে খালিদ ভাইয়ের কথা হলো এটা S1 Q3T3 এটা পালমোনারি এম্বোলিজমের উইথ আরবিবিবি প্যাটার্ন এটা পালমোনারি এম্বোলিজমের একটা ডিফারেনশিয়াল ডায়াগনোসিস আনা উচিত কিনা।
Definitely. But what would the point that you made, if you look at my arrow, even though it looks like a keyword, there is a tiny R wave there. So that's the part. It looks a little confusing, but you are absolutely to point it out. And also in lead 3, it looks like a wide Q, but in lead 2 and AVF, it's fairly narrow. It does not fulfill that criteria of 40 milliseconds for the Q wave. But these are all the valid points to bring forward.
Should we make any comment on the T wave, sir? Lead 3 and AVF, T wave?
Wadud.
স্যার আবার ইসিতে যাবেন স্যার।
I am back.
T wave, lead 3 and AVF.
The important point is that the T wave is inverted clearly in lead 3 and also partially in lead AVF. Maybe there is some inferior ischemia, but in patients RBBB, very skeptical of accepting that as ischemia.
Good. So how about this one?
This is completed RBBP.
Okay, the poll, please.
It's complete RBBP.
This is the first time 100% single.
No. Yes, not yet.
Police not to worry.
Yes, yes, first degree heavy block also.
But there is a right axis deviation, suggesting there is also left posterior hemiblock.
And this is RBD with first degree heavy block.
Is there a pacing? No,
No, there is no pacing.
there is no pacing, yeah.
So I think this is very good that right bundle. And Wadud made a point that it's extreme right axis deviation. There is possible right posterior fascicular block. So I'm going to move to another ECG. Let me see, I have it here. This is an ECG. If you could show it and then poll.
পোলটা একটু পড়ে দাও, একজন লোকজন দেখুক।
অলরেডি দিয়ে ফেলছে তো ঠিক আছে, থাকুক।
This one is inferior one.
Very good.
This is inferior one.
So what do you think? Pretty good, right?
C&D, right, sir.
I think it's basically majority answered with right bundle branch block, anteroseptal MI with inferior MI. And a few missed the inferior MI part. So basically, when you look at a picture, look at the whole thing. I mean, it's like when you see a beautiful young girl on the street, I'm talking to the boys, just don't look at the face, look at the whole person. So, so you just get amazed. So same with anybody. So I think looking at the global picture is important. And so this is right bundle with, you can see the Q wave in. So this ECG, look at, I'm going to bring another ECG for the same patient. Look at this alternate. Bundle branch block and next QRS is wider. And that brings us to that ECG that Javi showed. You know what we traditionally considered complete left bundle or complete right actually is not. There is some conduction still. And it here probably is an example that when it became wider, it is a true complete. And then what we got is a little narrower. So it can vary even without being the traditional diagnosis of complete and incomplete. That could have explained the ECG that Hafiz showed. It was kind of funny that I had this ECG just surreptitiously. How about this one?
Bifacial block, RBD, LHD. And
Okay. Any of our panelists, any comments? So majority answered number 4. And then next was number 3.
Khaled Mohsin?
Yes, number 4 is the most likely diagnosis actually. There is a clear cut right bundle branch block with left anterior hemiblock, and there is poor R-wave progression in the precordial lead, and there is also evidence of left atrial enlargement. This is the most plausible diagnosis is number 4. Yeah.
I want to pay attention of the viewers. Please
Go ahead.
answer. The way we are answering what is the rhythm? It's sinus. Always pay attention to that.
Yeah.
Next, is there what is the QRS complex? It's RBPP with, because of the axis deviation, that should have been left posterior fascicular block.
Anterior.
And
Anterior.
Left anterior extreme axis deviation. But no, this is right axis deviation. Look at this. Extreme axis deviation.
Dr. Khalid Mohsin, the right axis deviation, that is deep S12 in lead 1 is due to RBB. This is not actually right axis
so RBB doesn't
deviation.
The axis deviation unless it is associated with some degree of fascicular blockade. That is the problem. But look at that. Then again, we are saying what is the QRS another changes? Old anterolateral MI. Then again, any structural change. Left
Anterolateral. That's true. That's true. That's true.
What is the PR interval?
PR interval, but not first degree heart block is not there. It's just marginal.
No, Wadud, the PR interval is about.
One is white.
It's 220 to 240 milliseconds. So
then it's first block as well.
Yeah. So I'll make a comment that people who answered C, if you suddenly look at 2-3 AVF, looks like old inferior MI, but there is a small R wave in this, and that takes away the diagnosis of inferior MI. This is not a Q wave. Any negative component preceded by R wave is not a Q wave. Please remember that. Second, I think I'll go more in favor of left anterior. This axis, is it right axis or extreme left axis? The question is, one of the criteria used for left anterior fascicular block is QR pattern. That's a Q in lead 1 and a small R in lead 3. That supports left anterior fascicular block, then left. So those possibilities are, so I think that that makes probably the number 4 the most likely diagnosis.
Yes.
So let's practice this. I think I have 1 or 2 more ECGs and then we'll be done. This one, I think I've shown this ECG. I think we should look at it again and again. And another ECG that is always difficult for us is somebody comes with left bundle, ST elevation and chest pain. This is not a chest pain patient. This patient just in office ECG.
Yeah.
87-year-old.
This left bundle block.
Okay. So nobody said right bundle, which is good. And then there was, of course, the issue of left bundle only. The question is the Q wave in lead 1, AVL, and lead B. V6 is not a Q, just small RS pattern. So any comment from Wadud is the master of this?
Right, sir.
So the Q wave actually suggests there is MI.
Yes. Where is the location? In a normal person, if Q wave in 1 AVL is suggestive of lateral MI,
but this
in presence of left bundle,
I will go for anterior MI.
It is anterior MI. And because there is a hole in the lateral wall, and you pick up the septal negative EKG going away from it, from that V6.
Yeah.
And it has been proven by autopsy finding. If I'll show you, this is a very old paper. I was probably, how old I was? I was 2-year-old when this paper was published. And they did autopsy on left bundle and found that anteroseptal MI with left bundle, Q wave in lead 1 AVL and V6. 38 out of 39 patients had this finding. So that's the finding. So if you see a Q wave in, I think there is one more, and then this is actually how much time? What time is it? We have a few more minutes.
Yes.
This one and one more ECG.
আল্লাহ আমাদেরকে ইসিজি শিখাইছেন দিয়ে দেখেন স্যার বদলে
বন্ধু ভাই, আচ্ছা আমি একটা প্রোগ্রামে 10 মিনিটের ভিতর শেষ হবে, ওই সিসি থেকে ফোন করেছিল তো, আমি কথা বলছি, 10 মিনিটের ভিতর শেষ হবে প্রোগ্রামটা।
Fantastic. Wadud, that's good, right?
তার খুব চমৎকারই আসছে।
So majority answered high-grade AV block with 3-to-1 cut. It's interesting. When we see 3-to-1, we always say, we say 2-to-1 heart block, but 3-to-1 is a difficult term. When we use 3-to-1, we should say 3-to-1 conduction. That means out of 3, 1 conducted. So this is a high-grade AV. Complete heart block with ventricular escape is a possibility. However, if you look at the rhythm strip, there is a P wave before each QRS and 2 non-conductor, and that PR interval is constant. That takes away the complete heart block. Sinus bradycardia was an option, and whoever said sinus bradycardia, if you go back, when you see any heart rate low, always look for, see if there is any other P wave. I mean, it is possible. I have seen a heart rate of 28 in an athlete. But this patient, a heart rate, he's 73-year-old, unlikely, but can happen. But you see, there's a P wave, and there is another P wave, and there is another P wave. So that's excellent. And then we'll do the last ECG, and then we'll be done for today.
You're used to বাজে রেজলিউশন, so I think তুই আমার মনিটরে ট্রাই টু ক্যালকুলেট চালু।
Okay. Two physicians said atrial fibrillation with right bundle. One physician said sinus rhythm, sinus arrhythmia, first degree AV block. And these are all options because there is a degree of irregularity. And majority said number C. So if you look at the irregularity, there is a pattern to it. Little slower, faster, slower, and faster. And that takes away atrial fibrillation, most likely. And then I can see something which looks like a P wave. You can see in lead, this rhythm strip is V1 and 2, you can see this P wave. And possibly another P wave, another P wave. So atrial fibrillation is out of the question. Sinus rhythm with sinus arrhythmia, first degree AV block is an option. Wenkeba is an option. And supraventricular. But if we look at it, my arrow is here, there's a P wave, there is first degree AV block, and then there is another P wave. Why this is a P wave? Because if you look at the previous T wave, there is no distortion of the end of the T wave. And there is a distortion, that means this is the P wave. That's PR is prolonged. And then again, there is another P wave, PR is prolonged, another P wave, long. And now question is, I think there is a P wave over here, which is conducted, and there is a P wave here, which did not conduct. And then it comes back to short. Let's look at it. I have drawn the picture. I say there is a P wave here. Am I imagining it? Look at, I have expanded it. This QRS has a positive component and the one before does not have. That means this is because of the P wave. And the same thing is in lead 2 also. You see, there is something in before the QRS complex which is not here. So that was the P wave. And then what's happening? I've drawn the line, P, conducted QRS, P, longer interval, P, longer interval, this P goes to this one. And here I had to use my imagination based on timing, because this timing was 640 millisecond. And if I make 640, there is a P wave inside the QRS complex, which I think conducted, and this P wave did not conduct. And then it goes back to Wenckebach plot. So please remember this thing. Anytime you see group beating, consider all these possibilities, that sinus arrhythmia, Wenckebach AV block, or sinus noto Wenckebach, which is a very unusual phenomena to happen. And then this is the same patient on a different day. Now it's a little bit easier. PR longer, PR blocked, first degree, borderline first degree AV block, and then a prolonged block. So this is the same patient. So Wenckebach. And the other thing is that, of course, there are a few other findings. I'm glad that you all picked up that there is an old septal myocardial infarction, because you see there is Q wave in V1. V2, I don't know lead position, but V3 clearly has this, so old septal myocardial infarction. And again, Wadud mentioned that you can see this pattern, but this is not inferior MI because it's not present in 2 and AVF. It's just a possible Q wave in lead 3. Unless anybody has any other comment, I'll finish here.
Sir, assalamu alaikum. Rafique sir, assalamu alaikum. Sir, একটা question ছিল, সেটা হচ্ছে last week একটা patient, the patient came with chest pain, LBV, and ST elevation in 2-3 AVF. The patient was admitted in under Professor Ghulam Azam sir, and he opined for inferior MI, and basically it came out as inferior MI as the patient underwent CAG. So, and he also showed a paper that in presence of LBV, if there is inferior MI, the ST elevation can be seen and interpreted as inferior MI in presence of LBV, which cannot we comment as anterior MI confidently.
Yes. Yeah. Okay. So if you look, can you see my slide?
Yes, sir.
Yeah. So if you look at this one, there is some ST elevation in V2 and V3. This patient is not having chest pain. So this has left bundle, right? But look at 2-3 AVF. It's not elevated. So if this patient came with ST elevation, yes, I support that notion that yes, if there is ST elevation, patient having chest pain, that can probably tell about the inferior MI. Wadud, any comment on that?
Sir, ইয়েতে ক্রাইটেরিয়া অনুযায়ী মডিফাইড ক্রাইটেরিয়া অনুযায়ী কিন্তু ST elevation any discordant concordant segment is positive for MI, but it can say which wall.
Yeah,
you cannot always say which wall is actually
inferior. Yes, sir. His explanation was that because of involvement of inferior wall, and which is prominently seen in limb leads, and the LBV doesn't impact the limb lead that much than the chest lead. So we can we comment inferior MI in presence of LBV confidently?
Can I interrupt? For left bundle block, to call it left bundle block, you have to have QRS implicated in limb leads. One, yes. So limb lead is always involved. Chest lead is also always involved. But if there is ST elevation, concordant ST elevation, it's MI, acute MI. You may not be sure which wall is involved, but it's acute ST elevated MI. You can take the patient to the cath lab, or you can go for thrombolysis. You can be sure of that by seeing the echo.
All right. you.
Any comment from Rafique sir regarding this particular?
No, I think, I mean, these are difficult ECGs as always. But if the patient is having ongoing chest pain and you see the change, you have to take it for face value and use that as a diagnosis. I mean, if the question is, if the same patient comes without chest pain, came for a totally different reason, then of course it's a different story. But somebody coming with chest pain, we have to clearly think about it. I mean, same applies if you look at the Garbosa criteria, and then there is a modified criteria where they decrease the amplitude of the ST elevation. You pick up more cases, but you lose specificity a little bit, but the sensitivity goes up. So that's true for any kind of thing. And the audience and everybody must remember that there are gray areas in medicine. And that's where we come in as a clinical clinician and talking to the patient and making the right decision at that point, which is very, very important.
Now, finally, we did it angioplasty and right proximal RCA is revascularized.
That's the one thing, to take the patient to the cath lab. Azam has done that nicely.
No.
Tushar, can you send me those ECGs, please?
I will send it to you, sir.
Thank you, Azam. With the also picture of the angiogram.
Okay.
I don't know the video, just the occluded RCA and RA. So
video clips.
Okay, thank you.
Sir, Atahar sir, can we show the ECG of the week?
If Ribhu, just you show the ECG, and if
I've got the ECG, I can show it to you, sir.
But if just
that is the ECG, sir.
I think this is the ECG of the week, and this was sent and posted by Dr. Muqaddas Hussain Sadi, and I think the time is over. I think it does not need any discussion, as because this was actually case of the atrial flutter. Is there any comment about the diagnosis atrial flutter? Is there is no comment, we cannot actually Firoze. Dr. Sadi is not available here, and this is the ECG posted by him, and this is the atrial flutter actually post CABG case. Is there any comment about the diagnosis? Anyone participant or panelist?
Okay, I just make a comment for the audience, whoever answered. First of all, it looks typical right bundle pattern that we looked at so far. If you look at the ECG, it is very difficult to say it is flutter or not, but look at the first two beat in lead 2 and lead 3. In lead 2, immediately after QRS complex, you can see a negative component and then another negative component. That is the clue for the flutter. And then as you move forward, you cannot, because the rate is faster. And at that point, you have to just use your imagination. So please remember that you can see the flutter wave in the beginning of the tracing.
Sir, in the lead V1, in the middle part of the, that is in between the two QRSs, are these the P wave, sir? That is the flutter wave.
Yes, but here, the heart rate 128, that P wave, I cannot see a second P wave. So let's say if I make a diagnosis of sinus tachycardia with first degree AV block, is also a possibility, right? Here, I mean, you can see the P wave immediately after the T wave. And then if I call it a first degree AV block, so if somebody answers that, I have to accept it also. Don't you think so?
Yes, sir. Sir, then we can tell it, sir, that the initial part of the ECG shows the atrial flutter, then it is converted into sinus tach.
It is unlikely because we have a long rhythm strip. And then at that point, if we take double of that flutter wave, you will match exactly with the RR interval. That's the way you tell that it did not convert. So in the beginning of the tracing, what we are calling flutter wave, if we take two of those flutter wave, that rate will be exactly same as the rate later on. That means that was atrial flutter. And then when you use that, then you can say, yes, that wave that I'm seeing in V1 is one of the flutter wave, and the second flutter wave is inside the QRS complex.
Sir, in P3, if you look at the T waves are double peaked.
Yes.
And if you look at the before the QRS complex, there is a small, very sharp, very small, very near P wave looking like picture. So
Yes.
that gives 2 P waves for every QRS complex.
Right.
That gives
Yes.
to the diagnosis that this could be likely flutter.
Yes. But the problem is, if you remember my Wankeba ECG,
Yes.
I showed one complex without that wave and one with the wave. That tells you that's not part of the QRS complex. But here, I can use my imagination into that.
Yes.
So if I did not have the beginning of this ECG, I could not have definitively said this is atrial flutter with 2-to-1 conduction. I have to entertain all those diagnoses.
Sir, then for the discussion purpose, that is the atrial flutter, sinus tech, atrial tech, all we should consider. There's atrial tech also, sir.
Yes, of course. Of course. You have to keep all those into diagnosis. And one of the clue will be that if we take a prolonged rhythm strip and the heart rate stays exactly at 128, doesn't change, that will take away sinus tachycardia, most likely. So I think this is the thing about that ECG that is we cannot just overstretch ourselves. We have to entertain the possibilities.
Firoze, stop the share screen.
All right, good. Thank you.
You can conclude the session.
May I request Abdul Wadud Chowdhury sir to conclude the session, sir. Wadud sir, please.
I think today we have very interactive, very involved ECG session. And the answer pattern shows that actually all the efforts of our teachers is paying off.
Yes, sir.
People are making proper diagnosis, thinking in the proper way, and analyzing the things in a more subtle and more accurate, more, I should say, confident way. And that's the beauty of these sessions. And we are really grateful to Rafique sir, Hafiz bhai, and all the other panelists who are contributing to these sessions. And the expression of opinions, we differ with each other, give our opinion why I am saying so, and again counteract. This intellectual battle is so beautiful. These are sharpening our wits, sharpening our mind, and also making us more adept at diagnosing and analyzing the ECGs. Thank you, everybody.
So Firoze,
Yes,
as an announcement for our next Saturday's session, sir, Rubik sir, the same way the December month, in the month of the December, our discussion will be the same pattern. And the next Saturday, our presenters, Dr. Khaled Mohsin, possibly he is here. Dr. Khaled?
Yes.
Yes, Khaled Mohsin, get ready. We are waiting for your presentation next Saturday.
Only 20 minutes.
Okay.
22 minutes for you. Kanis Fatima?
Good. Good.
Kanis,
All right.
Kanis
Sir,
Fatima?
Achi, sir.
As a Kanis Fatima, actually we
Yes,
want
sir.
to hear a comment from you about the Chowdhury Hafiz, one of the ECGs, that is the very ECG that was discussed about the sepsis and the cardiogenic shock. Actually we wanted a
স্যার আমাদের এখানে তো আসলে ওরকম ফ্যাসিলিটি নাই মানে মনিটর করার, এই একটা তো স্যার প্রবলেম আমাদের, মানে অনেক বড় প্রবলেম আমরা ফেস করি যে, এবং স্পেশালি হচ্ছে স্যার এরকম সেপটিক এবং কার্ডিওজেনিক শক যখন স্যার আমরা একসাথে সাসপেক্ট করি, মানে খুবই স্যার মানে কি বলবো ডাইলেমার মধ্যে থাকি আমরা, এন্ড মোস্ট অফ দ্য কেসেস স্যার উই হ্যাভ টু ট্রিট বোথ, তো ব্লাইন্ডলি ট্রিট করতে হয়, করার তো কিছু থাকে না।
আমার মনে হয় যে আমরা শর্টলি চৌধুরী হাফিজের কাছ থেকে এই ধরনের একটা লেকচার মানে চাইবো আর কি, যে হাউ
জি
টু
স্যার, হ্যাঁ স্যার ভালো
ভাই, ঠিক আছে ইনশাআল্লাহ। আর কিন্তু আমি অদ্ভুত, যেহেতু তুমি ইন্টারেস্টেড, আমি কিছু 5 ফ্রেঞ্চ সোয়ান ক্যাথেটার নিয়ে আসবো নেক্সট টাইম, এন্ড আই উইল ডু ইট ইন ঢাকা মেডিকেল কলেজ।
স্যার আমাদের সোয়ানগঞ্জ স্যার আছে, কিন্তু স্যার ওভাবে প্র্যাকটিস করা হয় না। এখন স্যার কোভিড এর মধ্যে তো স্যার আমাদের আইসিইউ কোভিড আইসিইউ, এই জন্য স্যার এখন আসলে কমে গেছে আরো।
আমরা চৌধুরী হাফিজকে রিকোয়েস্ট করবো আমাদের বাংলাদেশি পার্সপেক্টিভ কিভাবে আপনার এই নলেজটাকে আমাদের এই ফ্যাসিলিটিতে কাজে লাগাতে পারি from your lecture. Actually, we are expecting your lecture in the next series.
Hafiz bhai, the point is hemodynamics during the other meeting.
Yeah, sure.
And another presenter our next day, that is the Aisha Kadir.
All right.
So Khalid Mohsin, Kanis Fatima and Aisha Kadir. Actually, we are waiting for the 3 distinguished faculties in the next Saturday. Kaiser Nasrullah, many thanks. You initiated the discussion to an excellent presentation. Nice ECG actually showed us. Kaiser Nasrullah.
Thank you, boss.
এত vigorous আলোচনা হবে এই ECG তে।
Thank you. I think Muqaddas and Sadi sir is also with us.
But Atahar bhai, I missed Firoze because I'm Firozeর স্টুডেন্ট হতে চাই, তো আমার সৌভাগ্য হয়নি কখনো হওয়ার, তো ফিরোজের লেকচারকে যদি কখনো মানে সুযোগ হয় আমি মানে আরেকবার দেওয়ার অনুরোধ করছি আর কি।
ইনশাআল্লাহ সাদি ভাই is with us.
সাদি
মনে হচ্ছে গানের অনুষ্ঠান আরেকবার।
সাদি ভাই আচ্ছা আপনার ডায়াগনোসিস নিয়ে তো ডিসকাশন শুনলে, ডু ইউ হ্যাভ এনি কমেন্টস অ্যাবাউট ইওর ডায়াগনোসিস, ECG diagnosis? You had got the 3-dimensional diagnosis.
With follow-up ECG, the patient presented us with atrial fibrillation ECG.
Oh, that was atrial fibrillation.
No.
Subsequent follow-up ECG showed atrial fibrillation.
That means it's a sick sinus syndrome patient?
No.
Just hemodynamically deteriorate করে গিয়ে atrial fibrillation হয়ে গেছে।
No.
Atrial flutter always transient and it
tends to atrial fibrillation. Atrial flutter
integration to fibrillation.
But what was your diagnosis of that ECG?
Is atrial flutter.
Atrial flutter. But we have also some differential diagnosis, that is the sinus tach or the atrial tachycardia. Do you have any comments about this differential diagnosis?
My differential diagnosis was also first degree AV block.
Sinus tach with first degree AV block. The very difficult disease that was.
Maybe.
But in that ECG, we do not have any P-wave that's upright in lead 2. Without an upright T-wave in lead 2, we actually cannot entertain the diagnosis of first degree heart block. That's the problem. Atahar bhai, do you want?
Yeah, I'm absolutely agree with you. Actually, the T was inverted in the lead 2. That is the academic discussion. That is the sinus tach is the differential diagnosis, but we can we can exclude the possibilities because of the inverted T waves in the lead 2.
It could be left atrial rhythm.
Right.
It could be atrial tachycardia. It could be atrial flutter. But that's a very interesting ECG. Sadi bhai, thank you.
Sadi bhai, thank you very much. Actually, we missed to Sadi bhai last 2 sessions, but actually we are waiting for you and we are happy to have you see your face. Sadi bhai, every time actually you are welcome.
Okay.
Thank you, sir.
Sir, may I add one comment,
yes,
sir?
Yes, please.
Regarding the first ECG of Ascensors. Actually, everything we can correlate with the hypokalemia, as because this hypokalemia may lead to the rhabdomyolysis. This rhabdomyolysis may lead to the ARF, and as well as the cardiac arrest. All these things we can compile under the single headlines. That is, the hypokalemia may lead to everything.
Asad, it was hyperkalemia actually. Rhabdomyolysis can give rise.
Sir, the hypokalemia induced may sometimes induce the rhabdomyolysis.
But the EKG, because it was mentioned that, remember there is Osborne wave that we need to recognize, and this hypothermia was mimicking. Our problem was that the patient had a cardiac arrest, but post cardiac arrest, it was sold to us as STEMI. So our thing is that tease out that what is going on. But yes, actually this patient did have hyperkalemia because of the rhabdo, and then got the bicarb and all that. There was hypocalcemia, hypomagnesemia. I don't know, Atahar bhai, whether you noticed there was a little bit QT prolongation also.
Right, exactly.
Please, bhai. My question was, I would have gone for temporary pacing, the correction of metabolic acidosis and waiting, instead of deciding it's a case of ST elevated MI. What did you do actually?
I was muted. So, but the question is, if the heart rate is 50s and the blood pressure is maintained with a little bit of dopamine, then you can buy time and correct all the, and if it gets worse, we have this pacer pad for external pacing. And then if we need to go, we can go and put a temporary wire. But the patient did well from the rhythm point of view.
He's lucky to have, he still had sinus rhythm. That was very lucky of him.
And then another political thing, if you put a temporary wire, the ICU will say, now you take care of the patient.
Thank you, everybody.
So, thank you. Thank you, Drew and Besim.
Thank you, sir.
Thank you all the other panelists, Dr. Asad, Professor Maski with us, Professor Moshin Hossain, Abdullah Jamil Bhai, Professor MG Azam, and also Professor Jalal sir was with us, actively participated.
Jalal sir was superb.
And Dr. Khalid also came back from Corona.
No, Khalid is actually here. Asa.
Khalid bhai, আপনার গলা আওয়াজ শুনাই দেন সবাই।
না ভালো আছি আলহামদুলিল্লাহ। Congratulations সবাইকে. For a nice and brilliant discussion from every part of the participants, beginning from participants to panelists, and Rafique sir and Hafiz sir is always, Atahar sir and Wadud sir. Thank you everybody.
Nice to see you, Khalid Zaman. Arun Maski, thank you very much. Actually, we cannot hear you today, but we feel your participation every day acceptable. Arun Maski.
Arun, please always prepare some ECGs. When you get chance, show us.
Deep courses, sir. 9.
Khuda Hafiz.
So, Firoze, tale ya karo.
Yes, sir. Good night, sir.
Good night.
Assalamualaikum, sir. Good night.
Assalamualaikum.
Thank you.
Thank you, Ribu. Thank you.
Assalamualaikum.
Excellent.
Assalamualaikum.
Assalamualaikum সবাইকে।